I'm not a thrill seeker, but I'm not afraid of risk. I figured if it's going to be tough anyway, let me do it in a direction where I can control my destiny to some degree and have a really big impact.
Most of us never question it. If you need to know what's going on below the surface of your skin, a biopsy is the only way. But Gabriel Sanchez thinks that's all about to change. He's the founder and CEO of Enspectra, a company building a new kind of imaging device that can see beneath the skin without actually cutting anything. Gabriel trained in bioengineering and spent years in academic research before leaving Stanford to build this company full-time. I talked with him about what it takes to create a new imaging technology and why skin is just the start. Well, Gabriel, thank you so much for taking the time to talk to me today. I've been really looking forward to this conversation together.
Absolutely a pleasure to be here. Thanks, David.
Yeah. What an interesting journey you've had. Did engineering at MIT, came to Stanford, got your PhD, you're working as an instructor, and to look in the crystal ball and see what you're doing now, not necessarily the most expected pathway. And I know for you, maybe that it wasn't what you were expecting. Tell me a little bit about what you imagined you were going to become one day when you were starting out your professional career.
A little bit circuitous for sure. Not exactly what I would have thought was going to happen. I would say that I was always deep into science and technology. I was interested in always in most things mechanical, robotics, but also computation code, programming, mathematics, and image processing, and all these sorts of things. So I had a diverse kind of broad interest and skill set. And where that led me was mostly into doing interesting courses and interesting research work in school. And it sort of just continued to progress one step at a time, where as I got involved in research as an undergrad, I got really into the space. I was working in a lab that was doing what was called bioinstrumentation. You would probably call that like wearables nowadays, but bioinstrumentation to extract data out of the body and kind of apply first principle and hard technology and engineering to biological sciences. And that just kind of moved me in that direction. And as I worked my way through Stanford, increasingly getting entrenched into this, really the biodesign culture, I started working on the side actually with several of the biodesign fellows while I was a master's student at Stanford, and got a taste of the biodesign process and got to see some of that, sort of that opportunity to do good medically and have a social impact through technology. And that just kept moving me in that direction. Now that, for me, as I got into grad school and I sort of started to see what avenues were ahead of me, that looked increasingly academic. I was really thinking I would go kind of professor track and work on great research and science that would really elevate, hopefully, the human condition. And maybe something that surprised me a little bit was as I moved through my PhD and then was instructing in the bioengineering department at Stanford, I started to change my perspective a little bit on some of the technology I had invented during my PhD, where I felt that it was powerful for science, it was powerful for academic research, but that it was likely to stay siloed in that environment. And so maybe useful for publications and general scientific advancements, but I thought it had a more practical use if we could get it out of that environment and get it into kind of mainstream science and clinical work. And so I took the plunge and actually left the university to start this company. And it evolved. We've gone through multiple pivots. We've gone through multiple interesting cycles, and now we're here. But always sort of driven by this passion that I really wanted to bring, in this case, the power of optics and imaging into the realm of the cell. And that just hasn't really happened yet. We've seen some exciting advancements in medical imaging, almost exclusively in the field of what we'd say radiology, which is more on the organ and tissue scale. But pathology has largely been unchanged for about 150 years. And so our goal is to move that in the same direction as radiology, where you could potentially go directly from living tissue to histology with no steps in between, no invasiveness. That's a really exciting future for us. So it's evolved, and I've tried to just keep evolving with it and motivated to hopefully make a good impact.
Wow. Well, I feel like our listeners could probably fast forward through this part and listen to the podcast and then come back and get a recap with what you just described. That consolidated more than a decade or multiple decades of your life. And, I'm hoping we can unpack a bunch of that together. You mentioned something, Gabriel, that I don't think is a foregone conclusion for people to realize about their own work early on, which is that the original technology that you're working on, or the original iteration, you shared that you kind of looking inward, recognize that this would be siloed, would not necessarily have broad impact in the immediate tangible way that one might hope. How you recognize that? Because that does not seem like an easy leap to make, especially when we're emotionally really invested in what we've been building.
Yeah, although I would say in this case, it wasn't that complex of a conclusion to reach because there was a lot of history. If
Mm.
basically just looking at the past, it was pretty obvious what was likely to happen with this technology. And so I'll get a little specific on it. So we were working in this field called multiphoton microscopy. And so it's an approach to deliver light energy into tissue. It's non-invasive. It has to be in contact, so you have to be able to contact the tissue of interest, and those photons get converted in a complex way where they excite natural fluorescence. And this was a theory that was proposed like in the 1950s by Maria Mayer, and then it had been advanced really by like Helmchen and Deck. And actually, one of my old professors at MIT, Peter So, when I knew nothing about what this, I was surprised to find this later as I worked through my career that I was like, I was right next to this all this time. And so it had been emerging as this very powerful lab-based research tool with cumbersome lab-based instrument. Think about like something the size of an espresso machine on a table that's 4 feet by 8 feet, weighs 500 pounds, and great for
A big espresso
papers.
machine, a
Well
commercial
well
one.
well, the espresso machine is the microscope. That's still, roughly that size, but you have to remember you need a laser to feed it, which is about the size of another small espresso machine, the optics to route it into it and condition the light so that it's proper for doing the imaging. Usually those lasers were running on a water chiller that was the size of a small refrigerator, and so you work all this up and you have this powerful lab-based setup, but you still largely are bringing tissue to it. So you're mostly extracting tissue. Maybe you're imaging small animals like mice. Skin was one of the weird places where we got some human data very early. I was telling you, my old professor Peter So, that you could sort of put your arm up onto a microscope and sort of touch the objective, and they were even to show. Even in the early 90s, they were able to show that you could see through the skin and see cells within the skin tissue. So that immediately opened up people's minds. They're like, oh, this would be useful for imaging cellular epithelium, cellular tissue, skin cancers. They were talking about that basically since the mid 90s. I started working on this in 2008, and it had really not advanced beyond that. It was an academic tool that was largely in use for 20, going on 30 years now, and no one could crack the problem of packaging this into a clinically deployable way. And so I had, in some ways, inadvertently done that in my PhD because we were trying to answer this science question in a completely different tissue. We were looking at skeletal muscle, but we wanted to
Mm.
image that in vivo and get data to power some interesting computer models. And the biggest problem was that we were trying to use this two-photon mechanism, and we were trying to actually literally lie people underneath it on like, say, a gurney and sort of strap them in place so that they wouldn't move, and try to get optical alignment between these optics so that you could get light into their muscle and get some images. And it was just very, very cumbersome. And I looked at that and I was like, we need a way to shrink this microscope and get this to the people. And then all of a sudden we'll be able to get all the data we want. And so I turned that into the core of my PhD thesis work. And when I had done that, and then we used that to run some interesting science and discover some things, and we published those papers. But I looked back and realized that we had probably cracked the main problem that had been holding this out of the clinic the whole time. And when I look back at the history of some of the best academic and optical research facilities and universities in the world hadn't managed to pull this off, I realized if we didn't really do it, it was likely just to stay in that state. I do think that has largely bore out. We, having spun this out, have really productized it, gotten the manufacturing in place, made it easy enough that anybody can use it. You don't need a PhD to operate the machine. Took it all the way through clinical trials and the FDA, and it is the only product still. Even as long as that took us, 10 years to do this. There's no fast followers. And so it was one of these things that was quite obvious to me that we had discovered a bit of a gem. And if we didn't bring it out, it was probably not going to happen.
And when you landed on the need case, that kind of core need that I'm sure we'll talk about more with the bottleneck and derm path and
Yeah.
all that. Some of us who've come through the biodesign world wear two different hats of biodesign: the sort of purist hat where you're looking for the unmet need in the sort of core pure experience, and then the consultant hat when you're working with a company that already has their product and they already have an unmet need, and they say, "Can you help us find more unmet needs that would be solved by this existing technology?" And I'm curious, is that how you approached finding this core need that you were serving, or was that already kind of knocking at the door in another conversation?
It's a little different than that. Yeah. So
Mm.
I was steeped in the biodesign process. I'd, been learning it at Stanford. I was working with biodesign fellows for, research credit and doing some side projects, and believe very strongly in that process as a pure form of identifying needs and then working your way to a solution. I think of this in a bit of a conceptual way, so I'll kind of go off on a tangent here, but that is a deductive reasoning process. You identify it, it filters its way down continuously. It's like we got a need, we need a, who's it serving, what's the problem, how would we solve that? Which is why I think it's a very teachable process. It's exciting because you can literally break that down to a discipline and a practice of how to innovate from a need to a solution, right? Now, if you think of this like a number line, or imaginary numbers or whatever, that to me is like the positive real numbers. There's this whole other number line, which is the negative side on the other side, or the imaginary numbers. So if you're not funneling down, but you're going from this way out, that's inductive reasoning. And so you go the other way and you say, what need exists that nobody knows about? But if they had this, they could not live without it. And you're actually working in the opposite direction. It's the same process, but nobody's asking for it because nobody even knows that it exists. You would talk to even now, you still talk to a dermatologist and they'll be like, my patients never complain about their biopsies. They don't know there's an alternative. They don't know there's any mechanism other than cutting your skin. The companies that are developing new skin therapies, new topical drugs and aesthetics, they test on animals or lab-based skin substitutes and simulations because there's no alternative, or you have to biopsy people. Nobody even thinks about these things, and so that's talked about a lot in biodesign. But I would say most of the discipline is this deductive process of let's narrow our way down. We were funneling our way out. So I do feel like we were disciplined to a large degree, but we were in some ways running the maze backwards. And the idea was like, if this had come first, would anybody want to cut into the skin? And we think no. But that's not the way history worked out, right? So you're in some ways you are fighting an uphill battle and you're going against the grain because there's entire history of 150 years of always cutting out tissue and putting it onto glass slides. That is how we diagnose and evaluate any sort of histology until now. Now we think that, we can literally touch epithelium, in this case, skin, because it's on the outside, completely non-invasively and digitize it without cutting it. So it's a mix. It was a little bit of a mix, I would say. But I think it is very important to adhere still to that concept of it needs to be needs-based. And that's really the biodesign mantra. I'm also in an incubator here called Fogarty Innovation. And the mantra here, I would say, is largely patient first. I think that's really our core sort of ethos. And so we keep those two things very central. It's just that we allow ourselves to imagine a little bit like what are the unspoken, let's say, novel needs or latent needs that are hidden beneath the surface because the technology itself doesn't exist to ask the question. And we have seen many historical examples of this, not so much in medicine, but certainly laptop, personal computers, the internet, cell phones, smartphones. These are often things that we could not have probably articulated as consumers or users or needs that we would want. However, once we see them, they become essential and they become integrated into our lives in a way that we really cannot live without. And so that's, I'd say, the approach that we take.
I want to hit pause quickly. We're coming up on one of the most exciting chapters in the many chapters of your story, but I want to make sure that I'm not assuming that our audience understands all the science here. Correct me if I'm wrong, but the way I think about your technology is instead of maybe cutting off a chunk of someone's skin and sending it off to a pathologist and having it get prepped and sampled and looked at under a microscope a couple weeks later. What you are creating might be able to accomplish that in real time in the doctor's office. Is that fair to say?
Yeah, so I'll give a little bit of description of the technology, right? So it's optics based. It uses a laser, which is scanned through the tissue, and it constructs an image basically line by line. So it's sort of scanning like a Xerox machine through the tissue, and that laser is a very special laser. So you hear of things like nanoseconds, but this is a femtosecond, which is a million times faster than a nanosecond. So there are a quadrillion of those in 1 second. It's extremely short duration pulses, and it's at such a short pulse that it actually it changes the way the photons interact with the tissue such that you're bringing near infrared light in, but it excites fluorescence, and you get natural fluorescence from all the different molecules in the tissue. And if you move this around, you can build up an image. And so what that means is by just touching the skin, you get a non-invasive image. It's under the surface. That's critical. So you're looking down into the depth, and it images in cross-section like you would normally see on traditional histopathology, and you get tissue contrast because of the molecular colors. So we see things distinctly like collagen, elastin, melanin, keratin. We can see hair shafts. You see the clear boundaries of the skin, which is, the epidermis, the living cell layer, the dermis beneath it. And all of these are structures in the active portion of the skin where we are typically looking for disease, and we're looking for inflammation or damage, or also looking for health signs of biometrics of health and renewal. And so what that allows you to do is exactly what you said. You can compress a process that would normally, one, be always invasive, and two, take approximately a week into a non-invasive process that you do in real time. We're really excited about that. I think of this as true, digital histology, going from living tissue to an image that you would normally see under a microscope, but non-invasively. Now, we use it for skin. It's actually much broader than that. You can basically use this on any biological tissue you can touch. The advantage of skin is that it's the one organ that we wear on the outside of our body, so it's completely accessible. But like I said, I developed this imaging skeletal muscle. So we were doing this. You can do it microendoscopically through optics and a tiny needle. You can do it through natural orifices. So, oral, vaginal, or even into things like the bladder. You can even think about intraoperative. If you're cutting into tissue and the tissue is exposed, you can image that as well. So this is where we had to have some of this discipline, this biodesign discipline, where we say this could go all kinds of places. How do we focus, right? And so that, like I said, this is where we're doing a little bit of this funneling out, funneling in, very much like the standard biodesign process of picking the right place to focus where we could introduce really a new imaging modality. And I think that's worth emphasizing, that when we took this to the FDA, this is the first new imaging physics, new modality they had approved in about 28 years. So you think of medical imaging, you think there's products every day, there's tons of them, but there aren't that many modalities. We have X-ray and histology are from about 150 years ago, the late 1800s. Ultrasound's maybe 70 years old. MRI and PET and SPECT and CT, those are all, maybe 50, 60 years old. They've been around so long, we just expect them to be there. The products we see most of the times are new variants, so it's intravascular or it's ocular or it incorporates AI, but they're not introduced. It's not like that's the first time you've seen an ultrasound mechanism. This device that we brought to the FDA, this is the first time the FDA has seen this physics. Fortunately, there's a lot of history of it in research, like I had said, but we were the first to really carry it as a product through that process. And so it was quite a challenge to actually figure out exactly how to do this, given how novel it was, and an interesting journey. But sets the stage now in the same way those other technologies also introduced a new modality, and now we have all number of variants of ultrasound, CT, PET, SPECT, whatever. Now we have multiphoton, and I do not doubt that we will have multiphoton for intraoperative, ocular, in different organs and different tissues as well, where it can spawn a whole new branch of medical imaging.
You talk about this focus that you needed to kind of bring to the problem or the technology, and this real sense of rigor. To me, one of the, if I were watching the movie of your life and building Enspectra, one of the the really big moments would be when you decided to go all in and to step away from your formal academic pathway with a young family at the time. I'd love to hear more about what that scene was like. And yeah, tell me a bit more.
The paper that I published that I was working on at that time out of my lab, the first figure kind of introduces the technology, but it shows this device being used on somebody's leg. That's my wife's leg, So we were, and she was in there helping me to kind of stage this and take some pictures and stuff. And we had our son in the pack and play sort of playpen over there in the corner of the lab. So we were starting our young family, and she was pregnant with our second. So when I was kind of making this decision, we had a toddler, a newborn, in Silicon Valley, which is outlandishly expensive and a lot of risk, but I think a lot of opportunity. And I thought it was an interesting time to give it a shot. And so I would say that I'm not a thrill seeker, but I'm not afraid of risk, and sometimes not just even risk averse, but risk driven, because I'm motivated by the opportunity, not necessarily, the thrill of it. And when I see what you could get by taking the shot would so much outweigh what you would pass up by doing nothing. Basically, you get nothing by doing that. Now it's very risky. I was on an interesting academic path, and I thought an interesting direction professionally where I could have really gone into probably a more stable academic or research career. But I also looked around, and anybody who knows that there's no easy path, I think, anywhere. I think if you want to be a tenure-seeking professor at a new university, you're in startup mode too. You're running a lab, you're managing a team, you're hunting desperately for grants, and it's pretty chaotic and difficult. And so I figured if it's going to be tough anyway, let me do it in a direction where I can try something that's a little bit of my creation, and where I could control my destiny to some degree, and I thought have a really big impact. So that was the decision. And your family goes on that ride with you, so they have to be on board. And, bless my wife, she is extremely strong and very patient and very supportive. And I am very grateful for her. And my children just think I'm weird now. My son is now 16 and in high school and driving, and my daughter's 13. And they're like, now Dad works on skin, and he's working with beauty companies and things. I don't know, but they've all seen the machine. They've grown up with it. They've seen their skin like under the microscope. They're probably some of the few people in the world that can really claim that. So it's fun to kind of just get everybody involved in it, for sure.
Oh, I bet. Wow. And everyone involved in the highs and lows of the adventure.
Yeah. Yeah, absolutely.
What was the first point where you started to feel like maybe this was going to work out okay?
It comes and goes. So you'll have my experience now in running a startup and running it for quite some time is that there are moments of great progress and strong signals of success and where you're going to go, and the opportunity of what and the impact of what you're building spread with long intervals that are fairly low. So I find that these exciting times and these big jumps, they are highly sporadic, and they're very intermittent, right? So we aren't always generally looking to the future, but sometimes it's just what's the next, major milestone, what's the next step, and it's like one game at a time, and let's go take on one challenge at a time. And as we start to eliminate those challenges slowly but surely, this story is crystallizing and coalescing into an opportunity that's looking increasingly exciting. There's some big ones, like the first one was, like I said, I had been imaging muscle tissue, and I got introduced by our good friend Paul Yock, who was he was the chair of my PhD committee, and had happened to talk to a dermatologist at Stanford named Justin Coe, and was like, I ever wonder if you could use this on other things. And I was like, I don't know, maybe. I started looking into researching this and looking into the literature, and found this is when I started to realize there was a lot of multiphoton work in skin, and it had basically just ran into a wall or plateaued as when it came to translation into the clinical environment, because of the cumbersome form factor and the inability to sort of deploy this in a reasonable way and in a feasible way. As I started to look into that, that's when I started to realize, I'm like, okay, this is a direction that we could really make a dent and really make a difference. Maybe I should just try to like adapt my system to see if I can image some skin really quickly. So I took basically a skunkworks weekend and kind of tore apart the muscle imaging system and duct taped together something that I could kind of throw on my skin, and I just plopped it on, and I saw skin cells for the first time in my forearm. And it was kind of, it was not a great image. It was not that wonderful, but I knew what I was looking at, and I was like, "It's going to work. We can get there eventually. Let's go raise some money. Let's go build a team. Let's go start refining the technology, and one step at a time, one step at a time, one step at a time." And then we've hit some great milestones along the way. They are far between, but they give us the juice and the energy to keep going. That first time that someone other than yourself runs the machine and is able to get data, and then you start running your first pilots and seeing consistently the information that you're expecting, and then rolling out in your first formal clinical trial, packaging that into your FDA submission, getting the FDA clearance, getting the breakthrough designation. These are big steps for us, that continuously validate us. And then along the way, I will say that you need a little bit of luck and timing too. It's taken us a long time, but one of the nice things about that is I do feel that the field of skincare has evolved tremendously in a direction of science and embracing this and thinking of skincare from an organ perspective, not just like vanity, but like making your skin healthy. And that is very well aligned with where we are right now. So it may have taken us a while to get here, but the timing is pretty exciting right now, where that field has increasingly sophisticated and complex biology focused on boosting the overall health of skin. The idea is, if make the skin healthy, it can largely take care of itself, reduce inflammation, be probably more resistant to malignancy, and it will look better. But you need readouts. So you need ways to measure that if you want to be able to deliver these types of therapies and get the kind of results you want in a systematic way. And so there is a very strong demand right now for visualizing and measuring exactly the things that we're good at. And so this is a very exciting time. This year in particular looks very exciting because of this push for longevity and regeneration approach to skin. And as an analogy, and coming from a muscle lab, we used to study everything from elite athletes through severe neuromuscular disease and muscle wasting and sarcopenia. And so you could look at like lifting at the gym as vanity, and you say you're just trying to make yourself look good on the beach. But we know that resistance training is tremendously valuable for mobility and quality of life as we age. And so there's a huge medical benefit to that approach. And I think we're seeing the exact same perspective coming into the field of dermatology and skincare, where we're starting to realize this is our largest organ. It's a high turnover organ, and it's in contact with the environment and exposed to ultraviolet and toxins, and is intimately connected within the body. We even find things now where there are non-dermatologic diseases that echo in the skin. You can get a pretty good diagnosis of Parkinson's just by looking at a skin biopsy, believe it or not, because you'll have some of the same degradation pathways in the brain with plaques, and some of the nerve degradation are happening in the skin, and you can see that. This connectivity, this movement is very exciting, and I think that the timing of that gets us very thrilled. So that gives us motivation. We keep going. And I don't know if you're ever done. Maybe that's the answer to your question. I don't know if there is ever a moment where you're like complete, I've changed my perspective on that. I think it's a process. It's continual. I look to my kind of heroes like Dr. Fogarty, Paul Yock, Josh Macauer, and they to me, like when I first met these guys, I like, they've got it made. They're still going, you know. Lisa Earnhardt, she's still going. Like, she does, like, and I'm like, if they're still going, like, I'm never gonna stop. I'm just gonna keep going. So,
Gabriel, you have such a humble way of talking about yourself and about what you've been doing. When I look at the things that you've done, I see someone who really dives into the strategy from how you approach fundraising, from how you design your study trials. And one thing that kept jumping out to me from what you've spoken about publicly and what people have described about you is this real focus on failures of technologies that have come before you, what we sometimes talk about as graveyards in the tech space. Could you tell me a little bit more about that?
It's an interesting topic. It's a little bit controversial, actually, in the traditional biodesign process. It can go either way. When I was coming up through Stanford and learning it didactically, like as the curriculum from the course, there is this idea of like, kind of stay pure. Don't, you don't want to bias your thinking, right? I actually, and I understand that logic. It makes a lot of sense. So you're working on a problem. You don't want to bake in a solution. You don't want to corner your mind into thinking into certain solutions. And so it is not a bad idea to approach this with fresh eyes and fresh perspective. However, I almost never do that. I am very interested, deeply interested in understanding the entire spectrum of what has been tried and what has not worked, and what has worked. Sometimes you find gems of what has worked in the solutions that didn't, and why, and I tear into those very aggressively. But it takes a certain discipline that when you move out of that research space now into the brainstorming, you do have to separate yourself from that and say, like, can I take all that information that and synthesize this into the patterns that are going to lead me to a pathway that will give me the solution that I want. And thus far, I feel like I've been able to do that. And I draw a lot of inspiration from some of these failures. And I look broadly and in weird places, So I studied space telescopes, binoculars, animals, the animals with the best night vision, like we're always looking everywhere for how do we squeeze a few more photons? Why didn't technologies of the past work? Was it a technological failure or an implementation failure? Or was it something wrong in the assumptions, or was the technology not ready, or a piece of the technology not ready? And then maybe that's available now. So that's something that we can take advantage of. And so I seek to get to, I call that kind of going deeper than knowing. You need to understand, like you really need to understand base principles and fully immerse yourself in whatever this condition is or this problem is that you're trying to solve. And when you get to that point where you understand how, not just what things do, but a little bit of why and how, now you can get really creative about bringing new different approaches together. And so I've taken some very unconventional, honestly, approaches in our technology when I was developing this at Stanford. Also, partly because I was naive and new to the space, and that is a huge advantage. We talk about this all the time. Ignorance is, or maybe naivete. Maybe you don't want to be arrogant or anything, but naivety, like, it's good. It brings a fresh perspective. You were like, they're like, lenses are always oriented this way, and you're like, why? Because we've always done it that way. That's the way we're. But you start looking at it, you say, well, like, do I really need that? I could actually get some advantages if I do something a little differently. And we've done some of that. And so we do some things that are a little contrarian, but we have control over the whole system, and we can take advantage of that in ways that we get performance that no one else has been able to achieve before. And by taking that system level approach, we've been able to really succeed, I think, where others haven't. We have to now execute that from a company perspective. I mean, at the end of the day, these things do have to be commercially viable, right? So now how do we get that out there in a scalable way that then does bring this to the masses and makes this a successful corporation as well as a successful science initiative? And we do think we have that. And so that's really the phase that we're in presently.
It's so interesting how you talk about going broad, then maybe even a little broader. And I think of, Steve Jobs spoke publicly about a time in his life when he was auditing classes at Stanford. I think he had dropped out. He wasn't a student, and he took a calligraphy course. And how years later, when they started building this personal computer, how they had this intense focus on, really an aesthetic focus on the beautiful design in their typography, which kind of connected back to this random course that a computer programmer took on hand-created calligraphy.
Yeah, you can draw inspiration from all kinds of different places, if you're looking, and if the thing that stays central is the goal of what you're trying to accomplish. But if you have some flexibility and a broad view, you can find things all over the place, whether that's in nature, bio-inspired, that might be in technologies and completely different applications, or approaches in completely different applications, but they're translatable into the problem that you're trying to solve. And then that gives you new Legos to combine in new ways to get new performance. So it's very exciting.
One thing that we both alluded to a little bit as sort of like a given here, but I'd love to ask you to really kind of underline for us here, is the core unmet need that you are solving by, in particular, approaching skin biopsies right now, or sort of that space. Could you walk through what's wrong with that space right now? Like, what's wrong with going to a dermatologist and getting a shave biopsy or punch biopsy and having that sent off to the lab? And what do you see that all those people who are immersed in the field might not have recognized for so many years?
So if you look at that space, it's highly inefficient. Now, and this is the usually the environment in which you can find some very exciting needs. And that's not saying that they aren't effective, but what you find is that they've built an entire machine around a very inefficient process, and you get good at it, and that's where we hear things like you start to enhance and ingrain bad habits. And I don't want to say bad because I know they're treating cancer and they're doing and skin conditions, and they're doing very useful things. But there's a blindness to the idea that there could be a different way because for 150 years we just cut tissue. So use that as the backdrop. The way I see the problem, we have in the United States roughly 45 million visits to the dermatologist every year, and about 30 million visits or so to cosmetic dermatology and estheticians. So this is altogether, say 80 million visits for skincare. Okay. We have roughly 6,000 dermatology clinics and 10,000 dermatologists. So you have to get down from 45 million to 10,000. And that is a massive bottleneck. This is why when you want to go see your dermatologist, it can take 5 months. When you go into the dermatologist, they are seeing 4 people per hour. They're very good at it. These are brave people, soldiers. They are doing really great work taking care of these patients, but it is a traffic jam. And the reason there's a traffic jam is because the only way that you can have definitive knowledge of what you're dealing with in the skin and what care pathway that takes is through surgical biopsy, is through traditional histology. The standard of care is built around that, which means you have to get all those bodies into the clinic because they have to get a skin check. From the skin check, identify the lesions that then need to be cut for evaluation. So just to give you some numbers, the 45 million, that's more people than have diabetes in the United States. Of those people, we take about 15 million biopsies every single year in the US. Roughly 50% of those are ultimately negative. So
Hmm.
nothing that you really do, but you've got a lot of scars, and usually in
Hmm.
sensitive places that people care about. And then the rest of the people, they have something that needs to get treated. Predominantly, that's going to be basal cell carcinoma or squamous cell carcinoma. Those two cancers together make up about 98% of the cancer burden, and then 1% to 2% is melanoma. You need a lab-confirmed diagnosis to then be able to proceed to the treatment, which half of these are going to go to a procedure called Mohs, where they cut it out stage by stage, or it might be a surgical excision to then remove the tissue. When we look at that process, it's not like any other medical imaging workflow that I've ever seen. Because you break a bone, they don't cut your leg open to see if it's broken, or if you think you have something wrong. You got kidney stones. We don't just start doing open surgery. We have non-invasive imaging methods through ultrasound, MRI, and CT predominantly, where we can see inside the body, and then you can plan, and then you say, okay, how are we going to we're going to deal with this via drugs or surgically intervening or whatever. Skin, we don't have that. Skin, you go straight to the scalpel. And, it's generally been justified for things like skin cancer because skin cancer is important. You got to treat that. And these are relatively small cuts. But I think it's highly inefficient to have to force everybody has to go through that pipeline and that big restriction to be seen. And then ultimately wait roughly a week. That tissue goes to the lab. You got to wait a week to get it mounted onto a slide and processed. Even in the world of digital pathology, they're just scanning that physical slide. It doesn't change that process at all. And so you have what I see as a cut first sort of methodology. If there was a way to actually image under the surface and see those structures that you would need to support making your clinical decisions, then that could tremendously change this workflow. Compress a process that takes a week down into minutes. And you have to step your way there, because for all human history, we've only have one way to definitively diagnose anything, and that's with histopath. Even if you see a tumor like in mammography or something with either ultrasound, you still have to usually take a biopsy of that tissue to definitively, diagnose it and know what you're dealing with. And so that's a paradigm that has just existed for pretty much all medicine, that we have to work our way through that. So you're going to start by screening and identifying and triaging and ruling out things, and then eventually building up evidence and slowly working to a point where we think largely in these less risky cancers like basal and squamous cell, where you could actually impact a lot of the biopsy burden and potentially fast track people towards treatment when they need it and potentially avoid cutting when you don't. That's the clinical side. Now, on the aesthetic side, and the broader health side, there's a whole spectrum here. All skin cancer, in between, you have diseases and conditions that are not life threatening. So that's like vitiligo and melasma, pigmentary conditions, or atopic dermatitis, eczema and psoriasis, inflammatory conditions. And the spectrum moves all the way into the realm of kind of cosmetics and aesthetics, where they're all sort of driven by photo damage and inflammation. As you move increasingly in that direction, you start to lose the ability to cut into the skin because it's not really justified to do it for many of these conditions. And so that one of the things that directly affects is clinical trials when you're developing new drugs. And it's very hard to enroll people for, say, a topical therapy where you say, well, we also want to cut into you to see if this is working, kind of defeats the purpose. And it certainly defeats the purpose if you're in a space where you're trying to rejuvenate your skin, make it younger and healthier, but you don't want to punch holes in it, right? And so this is where you're sort of stuck with before and after photos, and you can't really get these hard science metrics. So we see this as transforming the whole field, all the way from beautiful to clinical to beautiful, right? And that you could, by injecting useful science with visualization that you can quantify, you can treat skin as an organ across that entire spectrum. And so it's not, and that's why I call it a latent or a novel need. It's not that like nobody's doing anything bad right now. They're helping patients, and they're solving serious problems. And I just think that they're doing it very heroically in a very difficult way. And it would be great if we had the same sort of approach that we have across all other medical imaging, which is like look first, then start cutting. That has not really happened in histology because you need cellular resolution and you need tissue contrast. And those are the two magic things that the approach that we're using multiphoton really brings. There have been other approaches with OCT or high frequency ultrasound or reflectance confocal, but they're all monochromatic and various degrees of resolution. So this is the first, I think, true platform that really brings you equivalent information to histology. And we've proven that because we've run our clinical trials where we have literally imaged the same spot with our device before it got sliced out with the with the scalpel so that we could do head-to-head evaluation and comparison. And that was the level of alignment that we had to plan out with the FDA so that we could bring in this new physics approach to their review. That's a very long answer to your question.
I'm so glad you mentioned that trial design because to me that was such a fascinating strategy for how you were approaching patients that were already committed to getting this biopsy to sort of show how your technology accomplishes a similar level of diagnostic rigor. And I'm so curious if we said with a crystal ball Enspectra will be wildly successful at everything it touches. Things that I heard from you that you might go next is the oscopies, colonoscopy, endoscopy, all of these sort of lens on a flexible catheter mounted approaches. You mentioned this kind of cosmetics, pharmaceutical, cosmeceutical intersection. So many different areas. I could imagine in vivo imaging when we are trying to decide where's how much that we have to take for tumor margin. And we see Mohs surgery as with all these sort of little shave margins as kind of the most practical way that we do that right now. Where have you been thinking about the next step for Enspectra, and where is the fully realized dream across the board when you really imagine this?
Yeah, so maybe I'll clarify a little bit our near-term strategy, which is actually to launch in sort of the realm of cosmetic dermatology. There's a very strong pull for these real-time metrics and evaluations to assess the state of the skin health, to plan treatments, and to track the effectiveness of that. In that same realm, a little broader, there's a lot of interest from pharmaceutical companies and also beauty companies that are moving increasingly pharma-based and a little more evidence-based, where they want to build evidence and back claims on their products. And we like this environment because, one, there's an immediate pool and a nice commercial pathway, but two, it overlaps directly with the clinical space. If you're in cosmetic dermatology, even a cosmetically focused practice, they're still going to be also serving medical patients. And so that gives us a way to start to build a presence and the evidence to start to move in increasingly into that realm of clinical applications. And in that realm, our first target's really going to be non-melanoma skin cancer, basal and squamous cell carcinoma. That was actually the topic of our breakthrough designation that we got 6 months after we got our FDA clearance, which was how would we use this specifically in NMSC with some emerging new AI tools that we're developing to sort of streamline that process. And so that would be the progression kind of in the near term. Now, beyond that, like I had said, this technology has been used in academic research to study a whole slew of organs. So we know that multiphoton is effective at imaging prostate cancer, breast cancer, liver NASH, glioblastoma, I think, all over the place, lung carcinomas, intraoperatively, Mohs mapping. I think all of these are very interesting. So I think like you said, there's a progression where you can go. I think that there will be a lot of interesting applications microscopically and intraoperatively when you're doing surgery. So I think about if you're doing a prostate biopsy right now, what if you had optics in your biopsy needle so that as you're probing in, you're actually looking for potentially malignant tissue and you bring that tissue back out and your yield is just so much better. And so you're not just like, poking everywhere. Similarly in the breast, you're doing mammographies and you want to get in there and get a sample, but you want to get good yield. You don't want to miss the tissue of importance. Intraoperatively, we're cutting tissues out. And can you assess the margins of those cancers so that you can clean them very effectively and not leave malignant tissue behind? Or, even rapid bedside pathology for when we're doing procedures and you don't want to close the patient up and potentially leave some malignant tissue behind, right? So I think all of that is actually possible off this backbone because it has been largely researched in the academic environment. And still the main hurdle has been that there hasn't been a way to translate that into the clinic. And I believe we're charting that course now. The first product that's actually deployable that way, when we got cleared, actually FDA created a whole new product class for multiphoton. So there is a direction now in which you can go into multiphoton and think about different types of form factors and optics, which even flexible, right? And so where you can start to really get excited about thinking how you would use this in the future. So I think a lot of those are possible. I'm probably still mostly focused on where we are now. It's like, let's get this into the clinic. It's been a long journey already, but I anticipate that it would have the same ripple effect that every other medical imaging modality has had, and that you will see variants of all varieties of multiphoton in 20, 30 years that are giving you cellular imaging throughout the body. And I think that'll be very exciting. And if that happens, we'll be very proud of that. Yes, for sure.
Last question. What advice do you give to someone that is inspired by everything that you've built and what you're building now, who really wants to make a difference in the world, but doesn't yet have that insight into what they can work on, what they should work on? What do you tell students like that, engineers, people who want to make a difference?
I'll answer your question directly, and then I'll answer it a bit facetiously later. But so for that question specifically, I say take opportunities, seize them, because you do not necessarily know where they will lead you. I certainly did not. So if you have this like broad, grand vision of where you want to be in 5 or 10 years, sometimes that paralyzes people because they're like, oh, I want to run a company, and so no, I don't want to do an internship in this big industry or this big company or with this lab or whatever, because that doesn't move me in that direction. And I think constantly when I talk to people that have succeeded or that are doing really well, you look backwards, it connects, as they say, it connects in reverse. But when you were going forward through it, it was not very obvious. And what I've been just like opportunistic about working on engaging projects with exciting people that are willing to teach you and give you some experience and a window into a new space. In my opinion, new is even better. Worst case, you're going to learn something. Best case, you're going to find something that you actually kind of enjoy. Like I did not know I would have liked optics, for example, had I not snuck into this space and didn't realize. I would never have known I had a knack for it. But just kind of take the opportunities and don't overplan that too much, and cut yourself a little bit of slack to explore and try these different things. And I do think that's good advice. I think just like, don't pass on what might seem like an imperfect opportunity, like, it's an unpaid internship, or, that's not really, I want to be in this field, and it's kind of adjacent. You will, I think, be surprised, is my I hope. I've seen that happen very regularly. And I think just go in there with a good attitude and an open mind and take advantage of it. Now, the facetious answer is, I'd say, don't do it. It's like, it's too dangerous. It's too brutal. But the key to this is if Gabriel right now had told that to Gabriel 10 years ago, I want to listen to I'd have been like, no, I can do it, So don't listen to me about that. Just like follow your passion and keep going. Gabriel today would have been like, it's going to take you 10 years. And I would have been like, I can do it in like 6 or 7. But whatever, it's fine. So have some of that confidence, stay committed to kind of your core values of what you want to accomplish, and be a little flexible though with how you might get there. Like take advantage of people with energy that want to pull you in and want to try something new. Worst case scenario, you're going to learn something new. And you're going to meet somebody, and just meeting people, maybe that's the final thing, is maybe one of the most important things. Networking can be so valuable. I've worked with groups in directions where professionally I will never go again because that's just not my passion for what I want to work on. But those connections are invaluable because you're a hard worker, you're hungry, they like you, and somebody's looking for something like you, and they make recommendations and they connect you, and that's how you move forward. And so I think just network like crazy and take advantage of whatever opportunities come up, and do that with some energy. Absolutely.
Gabriel, this has been such a special conversation. I'm so grateful to you.
Oh, thank you. Yeah, no problem. I really enjoyed this. This was a lot of fun.